going to discuss the coronavirus, also known as COVID-19. We'll be reviewing the outbreak to date, how you can continue to prepare, ways to keep yourself healthy and safe. We do ask that you write all questions in the comment box down below to the right, and we will try to address as many questions as we can throughout at the end of the webinar. Also, please remember to keep your computers or phones muted. Although the first case of coronavirus was discovered December 2019, the United States did not receive its first case until January 2020, in which already there were over 9,000 cases at this time globally. In January, the pandemic was discovered or declared, and at this time there were over 110,000 cases throughout the world. This is a new territory in uncharted waters. As our lives have changed, we would like to provide you with some information about the novel coronavirus. At this time, I am going to introduce the panel. We have Stephen Holland, Church of God in Christ Urban Initiative, George Roberts, CEO of Net Health. We have Dr. Micheal Bosworth, Executive Director for Center for Population Health Analytics and Quality Advancements. We also have Dr. Rockridge Hannah, CHRISTUS St. Michael Health System, as well as myself. Okay, let's see here. So we will go ahead and get started with the agenda. Okay, so up first, we will have George Roberts with Net Health.
Good evening. Hope you all can hear me. Welcome and blessings to each of you guys. Is on a Thursday evening. It's almost the weekend, so move forward here. I'm going to try to move myself around here so I can look at the camera versus looking at myself. So I'm doing this a minute here while I kind of organize myself a little better. Hope y'all can see me. So it's a pleasure to be here with you. As I tell people right now, it's kind of like we're playing a football game right now, and we've just now started the second quarter. The first quarter was kind of getting our trying to figure this whole thing out, trying to learn the rules of the game, try to learn how to deal with the economy kind of shutting down more or less. How do we handle things? How do we start this whole issue of social distancing, which I had never quite heard of before about 2 months ago? How do we start living our lives a tad differently than what we're typically accustomed to? And typically, you guys who are her ministers, how do you essentially start having your services online, which is a totally different. You encourage people to come to your churches, all the time, and now you're telling people to not come to your church, but to watch you on Sunday mornings or different times during the day of the week online and streaming. So how do you do ministry in this new and different world? So and so as we kind of enter the second quarter now, we're starting to try to figure out how to open things up, and how do we start living with this crazy virus that's made our lives miserable now for the last couple of months. How do we start living in that world? And the reality is, as things open up, the virus has not gone away. So what things must we do now to try to move forward? So, and the idea of social distancing, staying 6 feet away from each other is still out there. We still need to wash our hands. I'll put our hands up here. We need to wash our hands for 20 seconds at a time. We also need to, one of the big things is stay home when you're sick. So often, and I have something in my pocket here. I'll show you in just a little bit. But so often in life, we think we need to, show we call our manhood, or, show how strong we are by staying, getting out amongst everybody when we're maybe not feeling top of our game. But so right now is really not the time to be doing that. We need to be staying home. If we're sick, we're not feeling good, stay home. And the reason is that it's not because we're showing weakness. We're showing strength by doing something that's unnatural to us, but we're also trying to protect our fellow man and fellow woman. So that's something that as you open up your churches, you need to be mindful of. That parishioner that maybe doesn't feel good that day probably doesn't need to come to church that day. And why is that? Because we don't want that potential parishioner who is may have symptoms of COVID, may not have it, but may just be feeling bad, to get other people in your church sick. What they first asked me to do too here is to kind of give you some updates here. So where we are in Smith County right now, our numbers as of this afternoon, we have 170 confirmed cases in our county. 95 of those people have actually recovered. So we have essentially, 75 active cases, and we update our recovery numbers on Tuesdays and Fridays. So we'll be able to show hopefully more recovered people as of tomorrow afternoon. And right now, one of the big things as we started this whole thing was to, basically we were trying to protect the hospitals. We wanted to not, we really feel like that many of us will get exposed to this virus and probably catch this virus over time, but we didn't want everybody to catch this virus all at the same time. Therefore, we have been paying close attention thanks to people like Dr. Bosworth and Dr. Ledlow and Dr. McGahey. They developed a hospital dashboard for us, and we know right now that East Texans and Tyler, Texas hospitals, we're currently at 43. And again, we'll have a different number on that tomorrow. We know that most of our most of our virus has been early on. It was through travel. Travelers brought COVID-19 into our Tyler, Texas, Smith County, and other places, and now we're pretty much it's all community spread. Age-wise, it's kind of interesting. In Tyler, most of the people that are positive are between 21 and 40. The next highest group is 41 to 59. So, we tell people that we're concerned about older people getting it. Well, older people in our numbers here aren't really getting it. The problem with older people is if they get it, they're at a higher risk of having a much more difficult course than younger people are. As a matter of fact, with younger people, particularly children, 73% of they say 73% of kids show symptoms. The other 27% may show no symptoms but still have the virus. And so going back to the number of confirmed cases, early on in this process, we had very little access to testing. But now as our testing has grown, we think we feel like that the numbers of COVID positive cases will increase. So we're watching that number. We don't want that number to go up, but the reality is the number will go up as more people are tested and potentially people who are asymptomatic know it. And so that's where we are right now with our numbers. So again, 170 confirmed cases as of today in Smith County. The biggest, what are the things that I'm worried about? What things concern me the most, and what makes our numbers go up? Well, number one, right now we've had COVID positive cases get into our low risk jail in Smith County, and so we've actually got a number of jailers and inmates that are part of that they've come back positive. So jails are one place that I worry about. Nursing homes are another place that I worry about. And the other thing we're seeing around the area is companies or corporations or packaging places, meat processing plants throughout the state of Texas and really around the country have had major issues with COVID-19. That's a big cause for the higher numbers in Potter and Randall County and Amarillo, as well as Moore County which is Dumas, Texas. So those are the big things there. So with that, I'm going to kind of pause my remarks, and Brandy, I don't know if you want to open it up to questions now, or if you want to just kind of keep going through our agenda and then have questions.
Yes, sir. We'll go ahead and continue as scheduled, and then we'll get the questions at the end. All right. So up next, we'll have Dr. Bosworth.
Hello, I'm Dr. Bosworth, and thank you for the introduction earlier, Brandy. And I'm really honored to be here to talk to you all this evening. I'm also a family physician, so I work in the Center for Population Health Analytics and Quality Advancement for our School of Community and Rural Health. But my primary training as a family physician, and I still practice. So I was asked to really kind of review some of the key things about coronavirus that you may have heard on the news or in the reading that you've done already, but just to kind of review just kind of the physiology and how the virus infects us, and then some of the things that we can do about it and to protect ourselves. Well, really, for the coronavirus to infect you or infect me, it starts with another infected person. And then this infected person has the virus that's replicating or reproducing in their body. And they get sick and are having symptoms and could be breathing or coughing or sneezing. And those viruses are attached to those, what we're calling respiratory droplets, and they get in the air. And there's two ways that that virus then can contaminate your body. So one, if you are around somebody within 6 feet, and that's why this social distancing of 6 feet has been so reinforced across the country, is that generally a respiratory droplet won't travel more than 6 feet. So if you're within 6 feet of someone and they're coughing or they're sneezing, and that respiratory droplet then comes into your mouth, or you breathe it up through your nose, it then lands on what we're calling what's called the mucous membranes. So the mucous membranes inside the nose and the mouth and the back of the throat, those are the skin inside the body that produces mucus type symptoms. And those are the cells that the virus can invade. Okay. And once that virus invades those cells, it takes control, and then it starts reproducing or replicating. And then your body then becomes the host. It's kind of like stepping on a mound of fire ants. All of a sudden you see one or two, and then it's thousands all over your feet and your legs. And that's what the virus does. It gets into your throat and your airways, and then it's like fire ants. It just starts reproducing and traveling all throughout your airways. The other way that you could potentially get the virus is, I talked about breathing in the respiratory droplet that has a virus on it. But the other way is that if you have an infected person, like I said, it starts with an infected person, that respiratory droplet gets coughed or sneezed out, and it lands on a table or a doorknob or something. And then you come up pretty quickly after you touch it. And then you touch it, and then because your nose itches, you rub your nose, or maybe pick something out of your teeth or whatever. And so now you have an infected hand, and then now you've just passed that particle into your mouth. And now that virus again has said, oh, there's a new home. I have a new host. And it does the same thing as if you were to breathe it in directly. And so that's why the hand washing is so important. And it's not that you can't touch surfaces, but you have to keep your hands away from your face. And so, and being very mindful if you touch surfaces, to wash your hands 20 to 30 seconds with soap and water, or using hand sanitizer before you were to touch your face, okay? So then once that virus gets into your body, it's almost like an epic battle from Star Wars. Your body wants to fight back, right? And so your body starts sending all these fighter cells to try to attack this foreign virus that's in your body and to get rid of it. Okay. Now, one of the really important things about the immune system is that it actually gets stronger when it has been exposed to different bacteria and viruses over time. So you think about kids, and maybe throughout your childhood, you have been exposed to lots of things, and your immune system actually gets stronger. Vaccines is how we make our immune system stronger. However, sometimes viruses, if we've not seen them before, and our immune system may not be able to completely get rid of the virus. So as our immune systems are getting revved up and starting to fight it, we start having symptoms of fever, cough, sore throat, some nausea, diarrhea, shortness of breath, maybe a loss of appetite or smell, and body aches, fatigue. A lot of these symptoms are symptoms from which the virus has entered into the mouth, the throat, and the airways. So for patients who get a mild version of this illness, about 80% of people, they'll recover within about 14 days. However, the more severe infections, especially people that are going to be hospitalized, it can take them up to 6 weeks to recover from the coronavirus. And when I say mild illness, I'm not saying that you're mild and you can go out and about and do your work, like you normally do. I'm talking a mild illness, meaning that you don't have to be hospitalized, but you would be able to recover from home, still probably feeling pretty crummy, probably feeling like you might have a case of the flu, fevers, etc. But one of the key things is that, the differentiating factor between people who get this mild illness versus people who get severe illness is people who have underlying medical conditions, and underlying medical conditions that actually make your immune system weaker. These are diabetes, for instance, hypertension, patients with cancer. A lot of chronic conditions actually on a baseline kind of dampen your immune system so that when you get exposed to a virus, it makes it harder for your body to attack it. Okay? So this virus doesn't care which host it infects. It doesn't care if it infects me or somebody else. It just wants a host. Okay? So it doesn't discriminate, but it's really those people that have weakened immune systems that it really wreaks havoc on. And it takes full control over the body and over those areas in the lungs and the heart, and puts a special strain on the heart and other organs. And that's why we're seeing people die from coronavirus, unfortunately. But what's really troubling to me is the disparity that we're seeing with the coronavirus. And we're seeing this especially in African American populations. And why are our African American citizens of the United States, are they having more severe infections and they have higher death rates? So why is this? And I really, in order for us to really understand this, I don't know exactly all the causes, but I think we can try to keep asking why to see if we can come up with some root causes. One of the things that I was reading from the American Heart Association is that 40% of African Americans have hypertension. And when I say hypertension, I'm meaning patients who have high blood pressure, that it's requiring medication. And 40%. So why is that? Why is 40% of our African American population have hypertension? Well, in digging down deeper in the conditions that are plaguing African Americans, they have a 23% higher obesity rate and a 72% higher rate of diabetes compared to other ethnic groups. Diabetes, obesity are risk factors for hypertension. And all three of those are going to decrease your immune system. So now we have higher risk of these chronic conditions that is prime for the coronavirus to be stronger, to wreak havoc in those patients. So why do African Americans have these chronic conditions at a higher rate than other Americans? Well, it's very complicated, and I don't know the answer to this. But there's a lot of reasons that can cause obesity and diabetes. Healthy food, lack of healthy food habits, lack of exercise or physical activity, increased stress, potentially mental health issues. Obesity and diabetes are complicated diseases, and they have a lot of factors that go into them that can cause those issues. In 2018, it was reported that African Americans were 20% less likely to engage in physical activity. Well, if there's 20% less likely to engage in physical activity, there's more risk to becoming obese and have type 2 diabetes. There's other things that are called social determinants of health. And these are a multitude of issues and really factors that go into whether or not people are able to access health care, and whether or not they are able to understand that the care they need. Such factors are lower socioeconomic status, having to do with different levels of education, different employment opportunities, different income levels. And with these different levels of income or employment opportunities, there may not be the benefits for health insurance. And if there's no benefits of health insurance or affordability of health insurance, there may not be access to health care to get preventative screenings and tests or treatment for chronic diseases. Are there other, racial or ethnic discriminations in the healthcare system? Are there neighborhood or work conditions that are not conducive to physical activity encouragement or healthy eating encouragement? Are the neighborhoods not set up or built such that there's access to food stores that have the healthy food options? So it's complicated, but I think this is a disparity that is very important for us to talk about and to recognize. And I know we'll get into a little bit more of that as the talk goes on. But one of the key things for infections for the coronavirus is that if you are infected, just like George was saying, stay home, stay hydrated, continue to nourish your body, take the medicines that would be prescribed to you, and really try to lessen the exposure that you might have to others. Okay, I'm done. Thanks.
All right. Okay, thank you, Dr. Bosworth. We will move along with Dr. Hannah, please. Dr. Hannah, I think you're on mute.
Can you hear me now?
I can hear you. Thank you.
All right. So if we look at it from the cure standpoint, there is no cure at this particular time per se for the coronavirus. I would like to say, as have already been mentioned, we have to do those things that are necessary to protect ourselves. The old adage says that an ounce of prevention is worth a pound of cure. So we have to go through the social distancing, wearing the mask, hand washing, self-quarantining. Those things that are necessary, we must do to protect ourselves in the environment that we're living in today. That does not say that there aren't in the process vaccines that are going to be developed. And with regard to the development of a drug primarily has to go through 3 different phases before it is introduced to the market. The first phase is called the phase 1 of a trial. And basically what's done there, we're looking, determining the safety of an agent that is given. So we look at a small group of patients and we administer a drug, or in this particular case, a vaccine, to a small group of individuals to determine the safety. What we do on a vaccine is to try to get the lowest possible dose that will produce the greatest response and be safe at the same time. Secondarily, the phase 2 part of a trial is the period in which we determine or look at how effective a vaccine is. And we examine and introduce this drug to a larger population. We're talking about hundreds of people receive the drug or vaccine in this particular case with various conditions, various ages. Drugs go through that phase 2 portion. And then finally, not last but least, is the phase 3 portion in which it's introduced to thousands of people. And we determine further adverse effects and some of the potential problems. Not only adverse effects, we want to be sure, because if we look at the last vaccine, probably it was effective at preventing the flu in about 40 to 50%. So we want to look at the efficacy of a particular vaccine. From looking at the vaccines, and I'll discuss later on with regard to the studies that are ongoing with vaccines at this particular time. But if we look at the genesis of how drugs that have been used for the coronavirus, initially there was a great deal of hoopla and celebration over the fact of a drug that was called hydroxychloroquine. And there was a great deal of interest in this particular drug. The drug was primarily used years ago for the treatment of patients who had arthritis. It was also used, drugs in that category was used for the treatment of malaria. With regard to hydroxychloroquine, or Plaquenil is the brand name, when it was reviewed in studies primarily, it showed no difference over not using a drug. And in some particular cases, in the VA study, there was a VA study that was done with 350 patients. And in the VA study that was done with 350 patients, it was actually shown that hydroxychloroquine actually could cause harm to patients, and particularly with regard to patients having heart problems. However, when combined with the drug that's called azithromycin, which is an antibiotic, which is, the brand name is Zithromax, and those particular problems were not noted. So the use of this agent should always be used, if it is used at all, should be used in combination with azithromycin. And primarily it has been relegated to be used in the hospital situations as well as for study purposes. The next drug that I'd like to talk about, and there is a great degree at this particular time of interest in this drug, and it's an antiviral drug. It's called remdesivir. This particular drug seems to show some promise in the treatment of the COVID-19. Remdesivir, some of the early studies that are out from NIH as well as from the drug company Gilead, remdesivir has shown that patients have a shorter duration with regard to recovery on remdesivir. Days are reduced from 15 days to 11 days with remdesivir, which is very exciting to know that you can reduce the recovery period. Secondarily, it has been shown with remdesivir that mortality rates in patients who were placed on remdesivir versus the placebo was like 8% versus 11%. It was not shown to be statistically significant. However, the trend toward a decreased mortality, or where we have fewer patients dying when they're placed upon this particular drug, is a very good thing. Because to gain ground, if we were to make the analogy football, if we'd make a 10-yard dash and we move up the field 10 yards, that's good. So with regard to this agent, also the Gilead, when they did their studies on it, the drug company did their studies, they found out that a 5-day course of remdesivir is equal to a 10-day course. So there is some excitement over remdesivir. This drug, however, cannot just be purchased on the normal mechanisms. There are various ways of getting it. Patients have to be in a clinical study. There is what's called the expanded access program, whereby it can be gotten from the particular drug company by the hospitals that need it. And thirdly, there is an emergency use program that is available through the company. And fourthly, there is a compassionate use program. And those are the various avenues by which this particular drug can be obtained. And primarily it's obtained for the use of individuals who are hospitalized or in a study. There was some excitement with regard to another agent, and this particular agent is one of the agents that we call a monoclonal antibody. And basically, the name of this drug, it's called sarulimab, mab meaning a monoclonal antibody. This particular agent, after being studied, did not show the response that was expected with this particular agent. And so basically the drug company has basically said that for their phase 3 trials, they're only going to be using this drug for patients with severe conditions of the coronavirus, because the efficacy with regard to sirolimus just did not play out. Another drug that's also in the monoclonal antibody group is a drug that's called tocilizumab, which is also another monoclonal antibody. And with regard to this agent, clinical trials seem to show that those patients who have severe symptoms with regard to the coronavirus, where it has been alluded to, where we have what's called a cytokine storm, where your body basically starts attacking the virus, but in doing so, it harms the lungs and the circulatory system at the same time. This drug has been shown to show some efficacy, and so there are clinical trials that are ongoing with it. But with regard to it, the risk versus the benefit must be weighed, because this particular drug can cause problems with the blood as well as problems with the liver. The next, but not last agent that I would like to talk about, and we don't primarily think of it as being a drug, and that is plasma from patients who have recovered from the coronavirus. And studies are being done with the use of plasma. People donate their blood and they get the blood plasma, and in that blood are antibodies. And individuals who do have the coronavirus, this gives their immune system a boost with regard to fighting the coronavirus. And this, of course, can only be used in those individuals who are enrolled in studies. And this is called the convalescent plasma usage. With regard to studies that are ongoing, I've already mentioned the remdesivir studies are going on with remdesivir, and they are looking quite well. Within the NIH trial, there are approximately 1,063 patients that are enrolled in this particular trial, and it's in 68 different sites. And I've already given you the results, the preliminary results, but we are waiting for the final results on the study with regard to remdesivir. With regard to the vaccine studies, there are a multitudinous number of vaccine studies that are being done throughout the world globally. About 102 or more studies are being done with vaccines. The list, out of those 102 studies, there are only 8 that have started to enroll humans into their studies. So the other 94 have not started human enrollment into the trials. And of those 8 trials, only 2 of those trials are in what we call, as I've already alluded to, are in phase 2 portions of the trial. And phase 2, and after phase 2 is phase 3. So basically, there are only 2 at this present time that are in the phase 2 portions of the trial. One of the agents or vaccines that's being investigated, it has to do with an endpoint, basically the prevention of individuals getting the coronavirus. And then the second vaccine that's in the phase 2 to 3, they're looking at the antibodies that are produced. And so we are really looking forward to a vaccine, hopefully, prayerfully, by maybe the beginning of next year or the end of this year. And that will be a wonder in itself, to be able to get a vaccine through that rapidly. Because vaccines generally take anywhere from 9 months to 2 years. And if we can and get it in the number of months, maybe before the end of this year or at the early part of this year, that would be a wonderful thing with regard to containing this virus. And there are global efforts, and there have been some joint agreements that were made with the drug companies so they can produce billions of doses of the vaccine. I would like to say primarily when the vaccine probably will be introduced, it's going to probably be introduced to those individuals who are going to need it the most. Those healthcare workers, people who are working in high risk areas where they will be associated with being introduced or exposed to the virus. And then secondarily, as we have mentioned or has been aforementioned, the age category, those individuals that are older who may be more prone to getting the virus. I would like to say also that there are 150 other drugs, and they're not in the human studies yet, but there are probably 150 other drugs that are being reviewed, from drugs like the good old-fashioned Pepcid that we see over the counter, which is famotidine, nicotinamide, which is an agent that was used for parasites. There are other agents that are being reviewed. They looked at some of the HIV drugs. They showed in the laboratory that they may be effective. However, when used in humans, they didn't really pan out. And so there are other drugs that are being reviewed, but the ones that I have mentioned on this evening basically are those that are going to be well studied, and they're going to be peer reviewed and going to meet the rigorous study standards that will be required for human use. And we appreciate you all. I would like to say, last but not least, there are studies also not only with the drug portion that I've discussed, but with the blood component, plasma portion. There are studies that are ongoing with the Mayo Clinic for patients who receive the plasma as a way of fighting against this coronavirus. Studies at the University of Chicago, Johns Hopkins. These are very credible institutions that we are aware of. And so we are definitely looking forward to an agent or vaccine that can totally take care of this corona or COVID-19 virus. And thank you all very much for lending me your ears and your hearts.
Wonderful. Thank you, Dr. Hannah. That was amazing and great information that you shared. I saw that a couple of people had logged on. Just wanted to make sure that you knew if you had any questions, you can comment to the bottom right of the screen, and we will answer questions at the end of the webinar. Also, I see that Dr. McGahey has added a great link there. You may want to take note of that if you would like to. It's in regards to the protocols for churches and places for worship. Okay, up next we have George Roberts.
Okay, can you hear me now? Good, okay, I'm on, huh? Brandy shaking her head, yes?
I can hear you.
Good. All right, so great job, Dr. Bosworth, and as well as Dr. Hannah. Just lots of, very, very valuable information. And, you've heard, how from a physician, how what's going to happen here, and Dr. Hannah can give you the vaccines and the treatments and things like that. So, I'm looking at my desk here. My desk looks kind of messy. It's because I guess I haven't been at my desk very often lately. So I look, Dr. Bosworth's laughing at me right now. I can see that, maybe somebody, but Brandy, I need a little help with the organization here, maybe, or something. So too much going on. Anyway, so what I'm thinking about now, so, I know some people on the call, Renthia Mason we did leadership title together. I won't admit for both of our sakes how many years ago we did it, but we've been friends for many, many years. And so what I'm thinking here, so how do you guys, as pastors, how do you start doing church at this point? What are things you should consider? And I had a long talk last night with the David Lukenbach, Father David Lukenbach, who's the pastor at my church. And we were going through a lot of things and et cetera. And so, some things for you to think about would be, first off, in your sanctuaries or where you do worship, how many people can you have in a service and still maintain social distancing? So we've talked about at Christ Episcopal, for example, Father David has gone into the nave at Christ Episcopal and has kind of measured things out. And he's determined that we can have 17 families in there and up to 50 people. So he's actually gone in, and I haven't been over there to see what he's done yet, but he's actually figured out, separating the rows by 6 feet, separating individuals by 6 feet. How do you do that? And so that would be a question for each of you to consider. How would you accomplish social distancing, and how many of your congregates can you have in your sanctuary at one time and be safe? So that's so number of people is the first thing. And secondly is, we talked about social distancing. Second thing I mentioned early on, I think you've heard, Dr. Bosworth mention it as well as Dr. Hannah, staying home when you're sick. So we always are, as a longtime member of a church, or, you guys as pastors, you're always wanting to encourage. I'm looking at Stephen here going, okay, I want people to come to my service. I want people to be there. And if they have a little headache on a Sunday is maybe not a good, may not be the best reason in the world. I'm see if I get a smile out of Stephen now. If that's a good reason for people not to come. Well, in this situation, the symptoms of COVID-19, and we talked about this, I've talked about this a lot, but it's basically a fever, a cough, shortness of breath, and now they're saying loss to taste or smell, maybe some chills, maybe diarrhea. There's some things like that may be symptoms of that. And you may have one of those, or again, you may be asymptomatic. So again, we don't want people to come to church if they're sick. And then as a pastor, so I'm looking again at Stephen, if you see somebody walks in that doesn't look like they're feeling very good today, how do you lovingly tell them it may not be best that you be here today? So that's something that you need to, I think, really think about right now. The third thing is, we talked about hand washing. So how are you is there a place that maybe as people walk into your church, maybe they have a little pop of hand sanitizer, or is the restroom close by where they could essentially deal with that? And how do you handle, hand washing, hand sanitizer, restrooms? How do you do that and keep those all clean? The fourth thing is, what are people touching? We talked a lot about cleaning and disinfecting services, and I've been trying to think about, well, most of our churches, what do they have in there? They don't necessarily have chairs. They have wood benches, or as we call it, lovingly, a pew. So how do you sanitize or take care of a pew? I'm not quite sure I totally know the answer to that, but there's got to be some way that you can at least wipe the top of where do people touch their hands? Like right now, I'm going to put my hand close to my computer. Well, I don't want to necessarily go touch my computer now, but how do you basically clean and sanitize your church? Well, one thing I know, what we're doing at our church, we're basically taking the books, maybe the books and maybe the Bibles, for this particular season, not all the time, but for this particular season, we're moving them from the sanctuary. Why? We're trying to remove things that people touch. So what do we replace that with? You replace it with the program, the worship, the bulletin, and maybe you have your hymns printed in the bulletin. Maybe this is the time in your church's existence. Maybe your paper costs have to go up because you're printing more bulletins for your people to use. So that would be a fourth thing. A fifth thing to think about is how do you sanitize your church? How do you clean your church sanctuary or where you do worship? How do you keep that clean? How do you sanitize that properly? So, because again, we know we talked a lot about cleaning and disinfecting services. How do we do that properly? And then we do it. My guess is if you're limited by how many people you can have in a service, perhaps you need to think about multiple services on a Sunday. How do you do that? And how do you properly clean and sanitize your sanctuary between services? And I don't have a real good, I need to do some more research on that myself, but I don't have a real good answer for you today on that. So how do you do that? So I think there's a lot of logistics. And the final thought is, so say I'm going to I'll look at Stephen again here. So say you have a congregate, you have a service on a Sunday, and one of your members comes in, and about maybe a few days later they call you and say, well, Pastor, got some news for you here. I tested positive for COVID-19. So what do you at that point? What do you do about it at that point? Well, you're kind of in a situation that how close did you get to that congregate? You know, for you, let's talk about yourself first. How close did you get to that person? Well, you know, if you're serving communion, if you're doing something, if you're doing things that you normally do, you probably want to make sure during this particular season, hopefully it's not a long season, that you're not going up and lovingly giving your brothers and sisters a hug or handshake. We probably need to maintain that 6-foot distance at all times. And, you know, typically I know when I go in the church, I want to, you know, shake hands, hug my friends. But in this season right now that we're in, I would ask that we need to refrain from that. So again, go back to my point about what do we do on that Sunday that 3 days later somebody calls and says that they've tested positive. Well, the first thing that we're going to ask on contact tracing is who are you 6 feet? Who are you within 6 feet of? And if it's Stephen Holland, then Stephen may need to take 14 days off and self-monitor for those 14 days. If Stephen was within six feet, then he's probably okay. And the final thing to probably think about is masking. You know, I'm having to buy in. That's something I don't feel very comfortable with myself. I don't like putting on a mask. Matter of fact, I had a mask on the other day when I was at the grocery store and started feeling a little lightheaded. And I talked to my daughter, who's a nurse, and she reminded me. She said, "Dad, you've been breathing in your own CO2 for a while, so that's probably part of your reasoning here." So, but saying that, we do need to think about wearing a mask while we're in worship together. And, you know, obviously, Steve, when you're giving your sermon that day, that's probably not the time to give take the mask off. But while you're interacting with people, keep the mask on. And again, the mask it's counterintuitive. The mask is not to protect me, it's to protect others from me, if that makes sense. So the mask is basically to keep my mouth covered. Here's my mask. Where's my mask? So I put my mask on. I'll just kind of hold up myself here. So I'm putting my mask on, and basically what it's doing is preventing those respiratory droplets, because I talk loud. I'm a big mouth, and so respiratory droplets are coming from my mouth. So basically, by putting on a mask, I'm trapping those respiratory droplets, which is how we spread COVID-19, is through respiratory droplets. So with that, and I saw a question, if it's okay, Brandy, I saw a question about childcare. I think that the deal there's got to be is the child, if you have access to a thermometer, I would, encourage you to have a thermometer and do something like that. I don't have a problem with childcare. I think that that's something that we have, something we want to do. But is the child, you don't want to have a sick child in there. And again, let's go back to the children. The children, if they get COVID-19, it's probably, unless they have some major, if they're major immunocompromised, they're probably not going to have an issue. But the problem is that child, if they get asymptomatic COVID, they spread it to mom and dad and grandma and grandpa, and we're really kind of worried more about grandma and grandpa. So childcare, I think, is good. Again, cleanliness, it's got to be a clean area, and you can't take a kid in that's sick. And that's kind of the childcare guidelines that we've been talking about for this period of time. Is the child can't be sick, and mom and dad can't be sick either. And we're sick being running a fever. So with that, I'll kind of pause here. And I think Dr. Bosworth has some more time, Brandy, if I'm correct.
That's correct. Thank you so much. Okay, Dr. Bosworth.
Thanks, George. Great points. And a couple things I'd like to add to what George was saying about reopening your churches is that don't open unless you're ready. And you really have thought through what your process is going to be and how to best protect yourself and your congregation, because there's no rush. And especially if your congregations are the majority are African Americans, if you think back to some of the comments I made earlier with the higher prevalence of chronic diseases and higher infection rates and death rates in African Americans. Opening up your churches when the coronavirus is still pretty prevalent in our society, without having the really good precautions in place, is probably not the best move. And so I would say really, read the CDC website. I know Dr. McGahey had posted the link. Think about the items that George has talked about, and also consider, a screening process, whether parishioners are checking their own temperature, or they're screening questions of symptoms before they're even allowed in church, or being able to really control the amount of people that would be coming in if you're trying to really space people out for social distancing. Perhaps, notifications or signups for different services, or having multiple services instead of one or two, so you can spread out your offerings to really decrease the risk. One of the other things I want to touch on is getting back to decreasing your risk for getting infected, but mainly also decreasing the risk of African Americans of having severe disease. And what does that mean, and how do you do that? And one of the beauties of this this panel discussion tonight is that we are really focusing on the Church of God, and which is predominantly African American, and how you all can serve as leaders for your parishioners and for the people that attend your churches, not only for religious and spiritual health, but how can you now help to lead your congregations for physical health? Because many people, you touch the lives of so many people, and now you're touching the lives of people that are highest risk from dying from coronavirus. And we know that. And so knowledge is power. And so what kind of plan can you put into place to start incorporating more healthier practices, whether it's in the church life, in terms of food offerings, or trying to change the culture within the church to improve it for more physical activity encouragement. Anyhow, I'm not an expert in that, but I just challenge you to think about that. Really decreasing risk for obesity and diabetes. It starts with, a few things, with just trying to eat healthier, educating yourself and others, and encouraging others to learn more about nutrition and learn more about the physical activity that can really help you on a daily basis. Some key things I tell all my patients are, especially with trying to maintain a healthy weight and decrease your risk for diabetes, and hence decreasing your risk for high blood pressure, is don't drink your calories, only drink water and milk. Don't eat if you're not hungry. Don't snack. Only eat whole foods, so fruits, vegetables, and really trying to eliminate processed foods and fried foods. The higher fiber content of your food, the healthier it's going to be for you, the more fuller you're going to feel, and the less you're actually going to absorb carbohydrates and fats. So eating high fiber foods is one of the healthiest things you can do. And most importantly, with the role that you all have in your churches, is being a role model for these behaviors, and trying to encourage these behaviors within your congregations. Okay, and I think, Steve, I think you're going to end it for us.
Thank you, Dr. Bosworth. Yes, next we have Stephen Holland.
Okay, thanks everyone for listening to this. We're going to address some of these questions. I see some really great questions coming in. Before we address these questions, I do want to highlight Brandy again. Some people came in late. Brandy, would you kind of reintroduce yourself one more time to everyone, explain a little bit about your role and what you're going to be doing, and how you can service us here in East Texas? Can you just do that for us
Sure.
one more time? Thanks.
Yes, no problem at all. So I'm Brandy Friendly. I am a research coordinator at the University of Texas Health Sciences Center in Tyler. So my job is working with the grant. It's basically working with translational science. A lot of people, when you hear that, you really don't know what it means. So translational science is filling in the gap between healthcare, and the community. So we're focusing on a couple of groups, Hispanics, African Americans, and the LGBTQ community. So here recently we had a meeting, and it's called the Community Action Board. And basically what that is a group of people from the community, and we talk and we listen to what we feel or what they feel the needs of the community is. So we are working around, it's 35 counties, which is equivalent to 1.7 million people in Northeast Texas, which is huge. And all of the area is rural, or mainly rural. And so we are just going to try to develop new programs in the area and try to meet the needs of the community. Thank you so much for having me.
Thank you so much.
No problem.
And so with that in mind, I was trying to pull up here just part of a presentation that I did recently. I'm not going to show you an entire presentation, but there are 3 slides that really speak to what we're dealing with tonight. And if you'll give me about 60 seconds to share those slides with you before we go into questions. This is what I call the change formula. I use it often. I hope you can see that. Give me a thumbs up if you can see that. Okay, great. The change formula is something that is really important as we look at dealing with this pandemic. We've had to make a lot of changes, and particularly as it relates to health disparities. We've had a lot of discussion about health disparities in the African American community, and I believe when you really look into research, this is what has caused the overwhelming death rate in African Americans is the health disparities that we experience: diabetes, and additionally high blood pressure, obesity. We can go on, the list goes on. Part of what Brandy's service is with UT Health and partnership in the community is to help us with these, and they really give us a focus and a new look. So the change formula is this: it's simple. It's our current behavior that's an element in both of these. And so we start to look at this, and one way that we change current behavior is your actions that are taking place right now. And that's one big thing about that. All right. Current behavior plus blank equals change. The first thing we talk about is intolerable pain. Intolerable pain is the unbearing feeling or reaction that you're unable to bear or unable to deal with. Why that's important: a lot of us change. You know, when things start to happen in our bodies that we can't physically take or deal with, we begin to change. It causes us to change. When we feel certain pains, we go to the doctor because we can't tolerate those pains any longer. Additionally, we have this situation that we've dealt with COVID-19. It's caused us to change. We started to see a great impact, and it caused us to change some things. Another way we can change is through vision. And this is sort of what this whole conversation is about: to give us a vision, the ability to think about or plan the future with imagination. And that is exactly what we want to do. As we began to do this, we want to make some changes, even as it relates to our services, even as it relates to how we function. We want to make changes. So with that said, we're going to address a few of the questions. I'm going to ask some of the frequently asked questions, and then I'm going to address some of the questions that we've had here. First, I want to scroll up and just address a couple of questions that we had early on. I think we addressed at the very beginning questions about returning to service, and we're going to continue to address that question. So I'll come back to that. There was one question here about white blood cell count. I think that would probably be a question for Dr. Bosworth. Is that something you want to ask? This question was, let me read it to you. What if you run a low white blood cell count how are you affected with this virus? Dr. Bosworth, can you address that?
Sure. Thanks for your question. And so depending on what your level of white blood cell count, so white blood cells are those fighter cells that I was referring to earlier that help to fight the virus or any kind of foreign particle or bacteria that might enter the body. And so if your white blood cells are normally low, then that would probably put you into a higher risk for having more severe infection from this virus.
Okay, great. Thank you so much. Another question we have here, I think this is for you, George. There was, if you have a briefing or update on this, is there an outbreak at Victory Park Apartments? And what brought this about? If you have any knowledge of that, George, could you address that?
Sure. So let me get over to the screen. So we've had several cases right in a row at the Victory Park Apartments. It's a apartment complex over close to Texas College. So we've talked to apartment management. We actually have put some signs out on city property out there, kind of trying to get the attention of the neighbors to basically take those extra actions. Again, we're not trying to, one of the things we feel strongly about moving forward is when we have areas or pockets that may have more cases, more than a couple cases, that we probably need to try to take some type of preventative action in working with the property owner, but also let the residents know, hey, this is going on. So, I don't want to scare you, but however, let's remember the things that have kept us, we have had things we have in our hip pockets right now. Social distancing, wearing a mask when we're out in public, washing our hands often, and not touching don't go around touching the everything at the apartment complex, the handrails, the mailboxes, all the stuff that you might touch in your day-to-day life. Don't touch it right now. And if you do touch it, make sure you have hand sanitizer and wash your hands quickly. So we want people to be mindful in those situations. So yes, we've had several cases in the last few days over at the Victory Apartments.
Okay, thank you. And while you're addressing that, here's another frequently asked question that I was going to ask you. Can you explain what community spread means? What does that mean? And what is that? Is that a good thing? Is that a bad thing? Is it something that means we need to exercise more caution? Exactly what does community spread?
Well, it's kind of early in this process, Stephen. When we first got started, most of the people that had contracted COVID-19 came from travel. It came from if they traveled, either overseas or if they traveled to Dallas or Houston or to New York or someplace else, and they brought that back into the community. So what's happened now is when we say community spread is basically, so right now, since I haven't left Smith County since middle part of March, if I get COVID-19, I received it via what's called community spread, meaning I obtained it in the community. It's so community spread, I wouldn't necessarily call it a good thing, but it is what it is. Basically, it means that COVID-19 is in our community, and the way people are getting it now is basically because they're interacting with one another in our community.
So
does that answer the question?
Yes, but let me dig a little deeper. Is it safe to say that because we're experiencing things here, more so community spread, are we going to see a decrease from it being community spread rather than it being spread through travel?
No, we will see probably an increase. That means it's more it's in our community, but it means basically the community spread means it's in our community. So therefore, we will see potentially more cases, and it will be community spread. We've continued to ask the question to people: did you get it? Do you think where did you travel outside of Tyler, Smith County, for example, or did you travel outside of Gregg County, wherever you are? Where do you think you might have obtained that? And again, most of the cases now, the vast majority of the cases are because people they've contracted this from somebody else in the community.
Okay.
So basically, community spread means it's kind of basically a definition to say, did I get it outside the community, inside the community? And now we're saying most of our cases, it's here in our community, therefore we're getting in our community. And again, go back to the whole asymptomatic thing. I strongly feel like there's more people in our community that have COVID-19 than what the numbers reflect. Again, because people, I may have it, you may have it, and we may not have a fever, may have a little cough, or the cough may feel like it's allergies, because what happens in April and May in East Texas, we all are sneezing and sniffing and coughing because we're allergic to grass and pollen and mold and everything else out there. So this is just the time of year. So it's hard. I talked to somebody the other day, and I was actually talking to her about her situation, and she said, "Yeah, I had a real bad headache, but I thought basically it was due to allergies." So again, when she was tested, she tested positive.
That's informative. While we're there was another question that was addressed, and we're going to get to all your questions. If some questions are relevant to another, I'll stay on topic. One of the things that seems to be coming up or really being talked about quite a bit is, I'm sorry, someone's trying to get back in. I'm also hosting our call tonight, and so I'm multitasking. One thing that seems to be an often question is how, on the community spread, on the virus, how are people dealing with this new thing from childcare? There was a thing yesterday for a new child virus that could be happening up in New York. 64 new cases. Are you hearing anything about that? A new child syndrome as it related to the coronavirus?
I have not heard that. I'm gonna look at Dr. Bosworth and Dr.
Okay.
Hannah to see.
Dr.
if they
Bosworth,
have heard. I have not heard that. Dr. Hannah, Dr. Bosworth, have you heard that?
I have. So there is it's I think the name of it is like a multi-system inflammatory syndrome. I'm not exactly sure what they're calling it, but it's very similar to another inflammatory syndrome called Kawasaki's that we've seen in children. It's very rare, but it does cause quite severe illness in children and causes them to be hospitalized. Children are increased risk from dying for that. Mostly they will be hospitalized, potentially ICU, so in critical care. But children are resilient generally, and most would recover from that. But that is a new finding that we're seeing, and it did come out as a report, Steve. I saw actually earlier this evening. I think you're right. It was around 64 cases of these new syndrome in children.
Got it. Thank you very much. George Roberts, let me tap back to you.
Yes, sir.
And maybe someone else can answer this. A spike in the wintertime, and possibly coming back stronger. This is from Reverend Mason. That's a great question. Is there a chance that this can come back in the winter? Are we looking for a resurge?
I've heard that question before. There has been a concern about, well, okay, so things are kind of, will the summertime, will this virus kind of drop back down and resurface in the fall? And I think the answer to the question is that we don't know. Again, we're talking about a brand new virus right now, and although it's a coronavirus, typically, it's the cold family, so typically the viruses you see, colds and stuff like that typically go down during the summertime, but then pick up in the fall and winter season. So will this follow the same thing? I don't know, and I would I would go back to Dr. Hannah and Dr. Bosworth on that to get their expert opinion on that. But my answer is maybe.
All right, let's go. Let's hear from Dr. Hannah first. We haven't heard from him in a while. Dr. Hannah?
My impression on it is, as we loosen some of the shelter in place standards that we have, where people are back out into the community, I would think you're going to see a second peak in terms of the virus reappearing.
All right. We'll come back to that. Dr. Bosworth?
because there are those individuals who have not gotten exposed, and when they go back out into the community, if they are not properly donned, they can perhaps get it. And I think as people see more people come out, there are individuals that are not going to be wearing their mask. And even now, as the shelter in place is has been moved back in terms of released, and I've gone into different places, and usually I've seen maybe 1 out of 10 individuals with a mask on. And so I would think that there would be a second peak.
Okay. Thank you, Dr. Bosworth.
Yeah, so I agree. You know, we still have cases in the community, like George was saying, and so the virus is here. It's not like the virus has left, and now we're opening the community back up. And so I too have experienced the same thing as Dr. Hannah. I've gone out to get groceries and had to run errands, and the vast majority of people I'm seeing have basically reverted to previous coronavirus, norms, where they're not wearing masks, they're not doing social distancing. And I feel like that is of great concern. And so, my preference would be that, as things are opening up, we open things in a very methodical way and say, we still need to do social distancing. We have to have certain standards in place. We need to do our mask and have our hygiene practices. I think, if the virus is still here in the community, more people are going to get infected. However, the more people that get infected, the less people that can get infected. So at some point we will plateau because there just won't be new people to get infected. And I don't know if it's going to be one peak, multiple peaks, if this is going to become a seasonal illness until we can get a large portion of the population vaccinated effectively. So I think there's a lot of unknowns. So George, you're completely correct. We don't know exactly. We just know, we just can make some predictions based on the data we have.
I'm going to ask one more question before we address, we have a couple of back-to-back questions that are really good about funerals and social distancing that I want to acknowledge, but I want to make sure while we're on this topic, we address it. Going back to church, we certainly want to have a plan. I think it's important. And tomorrow we open up salons, we open up barber shops, we open up nail shops, we open up lots of things that are important. I need a haircut right now. And, but I think it's important that we highlight here, listening to the protocols, that as African Americans, we're at a higher risk. We don't go to places that don't have a plan. Would you all concur with that? I mean, I don't think we need to go to I want to go to a barber shop, and I want to support, and I want to shop local, but I think it's important that we don't go to a barber shop that doesn't have a plan, that doesn't have a protocol in place. Would you agree with that?
I would. Yeah, I would, Stephen. I think that's absolutely right. And even I think Dr. Bosworth mentioned about the churches being opened up and said, don't open up the first time you think you can until you have a plan. I think having a plan is something that you should do. I know you can see my little graying locks here need to be trimmed right now too. And it's, I need to get a haircut. And I actually got the place I get my haircut. I got an email today. Basically said, okay, this is the way we're going to handle it. Basically, you're not going to come inside until you're ready. You're going to sit in your car. Our waiting room is not open. You come inside, you get your haircut. We're not blow drying your hair. And oh, by the way, you don't get the neck rub and shoulder rub that you like either. So basically, you're going to come in and get your haircut. Then you come in, get your haircut, then you're leaving.
Okay, good deal. Good deal. Same thing for churches. We don't want to discourage people from going to churches, but I think it's really important that we highlight that you don't go to a church that doesn't have a plan. I think that's really important. I think it's too important to people's health that everyone needs to organize and strategize a really specific plan. Let me address a couple more questions that were really good. This comes from Cedric Granberry, who is the leader of the Smith County NAACP. Concerning funeral services, in the beginning of the pandemic, families of those that succumbed to the virus were banned from viewing and attending even graveside services. What is the science behind the relaxation of this standard in the beginning? As well, what are the directives or standards for funeral directors handling those whom have expired from COVID-19 so that family members will know what to expect in such a delicate time?
Wow. Am I on? Okay, I'm on. So I quite frankly, I had not heard that they had limited funerals for if somebody had died from COVID-19, that it was limited because the person had died from COVID-19. I had not heard that. I'd heard there'd been issues with, making sure they were handling the body properly, when they were, removing it from the hospital or from somebody's home or from hospice or whatever it was. But I had not heard all that. I'm going to, again, ask Dr. Bosworth and Dr. Hanna if they have better intel or better answer to the question than I do here.
Trying to unmute. Okay. So, just to make sure I understand. So, at the beginning of the pandemic, there was family members that were prevented from even attending graveside services. So I would just say, if that did occur, that's because people didn't know any better. And, when we have something that's an unknown, and when they're not sure of how contagious, so could it be possible that the body could still be contaminated and somehow expose people attending a funeral? Again, I think that was just out of just the unknown, and probably being way too strict with those types of precautions. I can't think of any infectious disease, to my knowledge, where a deceased body would be the cause to limit someone to attend graveside services. Now, the only thing I would say is that limitations for graveside services or funerals may have to do also with trying to prevent large gatherings of people who may be infected. And so if you have a patient who died from COVID-19, it's very possible their family or friends could have been infected or also be carrying the virus. And then now you're providing a setting where other people could get infected. So that would be my comments on that. Dr. Hanna, do you have anything else you'd like to add?
I think in the governor's 62-page report, he alludes to the funeral home process, and that would be a reference that I would give. And also, funeral home directors have guidelines, or should have guidelines, with regard to dealing with COVID patients. I have been informed that and this is just a local issue that I've seen, is that there, with the funeral homes that are here, that are open air funerals that are done at the graveside, that there be no more than 10 individuals.
Okay, very good. Dr. Hanna, while I have you, and we're closing here in the next 5 minutes. While I have you here, Dr. Hanna, want to also acknowledge, due to the disparities of African Americans, what phase or what should we look for as a safe phase for us to return to going out in the public? And should there be a particular phase? We're in phase 1 now. How do you think we should proceed?
I think we should look at, partially we should look at the numbers. What are the numbers saying to us? with regard to African Americans in terms of mortality, are those numbers going down? In terms of African Americans, are the numbers? I mean, it's totally almost discombobulating to me to say that we make up 13.4% of the population, and however, you look at some of these statistics, and 60% of the mortalities, or 60% of the 58% of those individuals who are being infected by this virus is African American. Something else is going on. And I think when we see those numbers begin to come down, and there are some large studies that are going on, I would like to say there are some large studies going on looking at other variables like vitamin D, in terms of that being a protectant and boosting the immune system, and that people of color may have lower vitamin D levels, which may, and there's a big study going on over in England. I think they're going to be looking at about 17.5 million people. But when those numbers begin to come down with regard to African American populations, I think that could be part of a safety net, and definitely when there is a vaccine. But we cannot. We are a social people, and I think to go on and on and on without ever coming up with a way that we can worship, that's a very integral part of the African American experience, is the worship experience. And so, as have already been stated, we're gonna, and you have so eloquently stated as well, we must have a plan. And the plan is, I would think, would start with the numbers in terms of African Americans, the mortality rates, the infection rates. Those are, I think, some of the key indicators in terms of when we can go back. And just because you see numbers that are falling, I think there needs to be some delving into those numbers in terms of, because in many of the states, sometimes even when this began, there were no numbers that, basically gave what the racial breakdowns were. But when those numbers begin to fall for African Americans, I think that would be one of the key indices that we could look at in terms of. And then when we do start, we have to start, like you say, we have to start with the plan. And as have been so stated, with the 6 feet distancing, the wearing of masks, it's all going to be new to us. This is new territory, but for the safety of our parishioners and for our own safety, these are some of the things that we're going to have to do.
Okay, thank you very much, Dr. Hannah. We're going to wrap it up pretty quickly. There was another question about birth, mothers who are pregnant, contracting the COVID-19 virus. What's their mortality as well as the mortality of the baby? Could you share that, Dr. Bosworth? I'm sorry.
No, you're fine. So I don't know the exact numbers in terms of mortality, but pregnant women who do get infected, their child or their baby before it's born, and even after, are higher risk. So one of the things that this virus does is it deprives the body of oxygen because it's attacking the lungs. And anytime that the body, a pregnant woman has what's called hypoxia, so a low oxygen level, that means there's low oxygen getting to the baby as well. And so a lot of the reports that I've read about women who have been infected with coronavirus, they've had C-sections to both take the pressure off of the mom and the lungs and the heart from being pregnant, but then also to remove the baby from the infected body, so that it also can make sure it's getting the oxygenation outside the mom that it needs. And I've seen some really good success stories with that. But in terms of, I don't know the exact risk or other numbers. So, but great question.
All right, great. All right, wrapping this up, Dr. Mason, last question here. Well, 2 last questions. One, and I'm going to let Brandy answer this question, and that is, I'm getting to it. UT Tyler Health Science Center has presented some programs in the community on living healthy lives, diabetes, high blood pressure. Do they still offer those? Either you or I believe Dr. McGahey, either one can answer this.
I think I'm going to let Dr. McGahey answer that question for the simple fact that I'm employed through University of Houston, and I just remotely work and represent Tyler.
Okay, Dr.
You know, we still do, and Dr. Bosworth has more visibility on that because she manages those programs now.
All right.
But we do have some community-based hypertension programs and diabetes education, Ms. Mason. So we can try to get you more details on that after the call.
All right, very good. Do you want to touch on that, Dr. Bosworth, at all?
Sure. So we have two programs that we offer. We offer a prevent type 2 diabetes program, and that is basically a lifestyle change program that is completely free for participants. And then their other one is a hypertension workshop program. It's also completely free. Participants get a free blood pressure cuff. And both of those we have transitioned to a virtual format given the pandemic. We work with churches, apartment complexes, healthcare organizations. So if we can get, 5 to 10 people in a congregation or a community or an apartment complex that would be interested in having one of these workshops, that's actually on site, but now that we're doing these virtual, we've had a great interest and feedback on that. So I certainly could send that information to you, Steve, and then you could get it out to the attendees tonight if they're interested.
Great. All right, we're going to wrap it up. I want to highlight the last covered points that were really talked about tonight and add just a couple seconds to this. I'm going to unmute Dr. Roberts, Dr. Hannah, or George Roberts, Dr. Hannah, Brandy, and Dr. Bosworth, if you would unmute as well. So really some highlights tonight. We know, we really need to know our emotions do not dictate this virus. This is not something that you emotionally dictate and say, I feel like it's Mother's Day, and because it's Mother's Day weekend, I think it's a great time to do the Mother's Day things that we like to do. That does not dictate this virus. That does not dictate the spread of this virus. I think it's really important that we don't go anywhere that doesn't have a plan in place. I think we pay attention to the numbers and our own personal health, and not only our health, but the health of those that are around us, more importantly. Who do we come into contact with? Who are we making contact with every day? Are we coming into contact with people who are in those high-risk areas at the ages of 70 plus, diabetics? That's really important for us to pay attention to. More so, pastors, who do you lead? And just from a Church of God in Christ perspective, there were several conferences that were happening at the very beginning of this COVID-19 outbreak. Some conferences saw people infected at numbers of 60 or greater, 75 or greater. There were deaths that happened, fatalities that happened from some meetings. Of course, this was at the very front end of this. The information was not out, and we do have that information now. And so I ask you to definitely have a plan. And here's some things that are really important about a plan. Have you consulted an expert about a plan? Do you know what you're doing when you're disinfecting? Do you know what to disinfect? Have you consulted someone who knows what they're doing? Just something that you come up with without having knowledge about how to stop the spread is not putting together a really sufficient plan. So if you're planning on going back to services soon, consult someone who has expertise about disinfecting, about how to stop spread, touching base with George Roberts and his staff about some steps that you can take are really important things as you start to move forward. And again, we love our barber shops, we love our salons, we love our nail shops, but do they have a plan? And if they don't have a plan, it might be good for you just to wait on that haircut or wait on that hair appointment until they have a plan in place. Is your life worth that haircut that you want? Is your life or one of your congregants' life worth having your traditional Mother's Day service? Again, your emotions don't dictate that, and I want us to use wisdom, be wise, be smart, and it's not a lack of faith, and it's not operating out of fear, but operating out of abundance of caution. I thank everyone for coming tonight, joining us. As we get more information and we learn newer things, we hope to do this again, and hopefully on a different platform with all the different experts that we had and covering several different organizations. There was a lot of compliance that we had to go through tonight to make this possible. I thank each one of you for being a part of this. Thanks, Brandy, for hosting again. And as we get more information, we won't just do it just to do it, but we'll do this when we get some really pertinent information together that's related specifically to the African American community. I believe it's important that we do that because so many of the people in our communities are being affected. Some don't have a primary health care condition. And a lot of times pastors and leaders, we're having to give some of our congregants that advice. We know the healthcare crisis that we've experienced in our community way before COVID started. And so we want to make sure that we get this information to those congregants and serve them even beyond the pulpit. Thanks again so much for each one of you coming, and we'll talk to you again soon. God bless.
Good night, everybody. Good luck to you.
Good night. Thank you.
Thanks, everyone.
You're welcome. Thank you, Paul. Good job. I see Marinthia there now. Good job, Dr.